Welcome back to the sonographically important knee pathologies. So in the last classes, we have already discussed about some of the knee joint pathologies while we are going to proceed it further. And here we'll discuss about the pathologies related to bursa and cysts. So, Baker cyst, distension of the semimembranous medial gastrocnemius bursa, which result in Baker cyst. Right? Local irritation or inflammation may cause its distension, but more commonly it becomes distended with joint fluid through communication with the knee joint. This communication is acquired by a combination of degenerative weakening of the intervening capsule and increased intra-articular pressure in joint fluid from internal derangement. Present in 50% of individuals more than 50 years of age. In the pediatric population, Baker cyst may be associated with underlying arthritis or joint hypermobility. So it's a common condition, and most commonly that is the distension of the bursa in between the medial head of gastrocnemius muscle and semimembranous tendon, and it can be developed due to the increase intra-articular pressure and decrease in the strength, or you can say the weakness of the intervening capsule, or you can say the capsule of the bursa. So due to the weakening of the capsule of the bursa and increase in the pressure of the joint fluid, this can develop. And there will be a direct communication between the Baker cyst and the knee joint. So actually that will be the uh, accumulation of excessive amount of knee joint fluid. Accurate diagnosis of Baker cyst relies on identification of the characteristic channel or neck between the semimembranous and the medial head of gastrocnemius tendon, which connects the bursa to the knee joint via the subgastrocnemius bursa. The result is a C-shaped fluid collection, concave lateral, which wraps around the medial head of the gastrocnemius tendon, right? So that is actually the distension of the bursa. So the bursa will extend and wrap around the medial head of gastrocnemius tendon. So that will appear just like a C-shaped structure. And it is important to interrogate the neck of the bursa, because that neck will be present between the medial head of gastrocnemius tendon and the membranous tendon. Sometimes it can become enlarged too much. So here in this image you can see this is the medial head of gastrocnemius muscle. I'm going to open my pen, okay. So This is the medial head of gastrocnemius muscle. Eraser. Okay. So this is the medial head of gastrocnemius muscle, and the combination of these three tendons is anserinus, and this one is bicep femoris. So, and between the medial head of gastrocnemius and bicep femoris, and there will be neck of the uh, um, Baker cyst. And here you can see this is the medial head of gastrocnemius muscle, and this one is the semimembranosus, and in between the semimembranosus and medial head of gastrocnemius you can see this is the neck, which communicate this Baker cyst with the knee joint. Okay, so this is the knee joint, and this is the communication between the joint and the cyst. And it looked like a C around the middle head of gastrocnemius muscle. And this is in short exude. Okay. And long exude, you can see the extension of the bursa, and this extra bursa can get larger and larger to such an extent that it can reach to the mid part of the calf muscle. Uh, Baker cyst may contain anechoic or hypoechoic fluid, isoechoic or hyperechoic contents represent complex fluid. Hemorrhage or synovial hypertrophy, inflammatory are the result of proliferative synovial conditions such as pigmented villonodular synovitis, hyperechoic and shadowing intra-articular bodies are also commonly present within a Baker cyst. It is important to evaluate the inferior margin of the Baker cyst, and that will represent the extent of the Baker cyst extension. In the sagittal plane, which will normally well defined and smooth. The presence of hypoechoic fluid beyond the confines of the Baker cyst suggests ruptured Baker cyst. If there is any fluid beyond the limit of the Baker cyst or beyond the walls of the Baker cyst, so that could be uh, ruptured Baker cyst. So here you will see some of the images of the ruptured Baker cyst. This is complex Baker cyst containing free fluid with the low level echos and some echogenic bodies. So this is complex, you can say infected Baker cyst as well. So here you can see this is the limit of the Baker cyst. Fluid could be appreciated over here. And the same way, this is the limit of the Baker cyst, but fluid could be appreciated this region as well. And again, you can see this is the limit of the Baker cyst, but some of the fluid, complex fluid will be appreciated over here. And the same way like this. So it's mean in cases of any settings when their fluid can be appreciated beyond the limit of the Baker cyst, that could represent the rupture Baker cyst. A more chronically ruptured Baker cyst may result in a heterogeneous mass-like
Sir,
area in the calf. G.
excuse me, sir.
हम्म।
सर जो लॉन्गिट्यूडनल व्यू होगा वो सॉरी लॉन्ग एक्सिस व्यू जो होगा वो लॉन्गिट्यूडनली जब हम ट्रांसड्यूसर प्लेस करेंगे उससे कहेंगे।
हाँ जी बिल्कुल, इसमें ना सजिटली देखिए, हम जब शार्ट एक्सिस में देखते हैं, जो सबसे पहले मैंने आपको दिखाया ना, तो ये देखिए
जी
जो
सर।
सी शेप में हमें नजर आ रहा है, इसमें हम ट्रांसड्यूसर को ट्रांसवर्स रखेंगे यहाँ पे। ये दोनों, ये जो पहले वाला इमेज है, ये हमें इस किस्म की प्लेसमेंट से
जी।
मिला है, ठीक हुआ ना। लेकिन जो दूसरा इमेज है,
ओके।
इसमें हमने ट्रांसड्यूसर लॉन्गिट्यूडनली प्लेस किया हुआ है। इसमें होता यह है कि जब जब ये डिस्टेंड हो जाए बरसा, तो तब जाके हमें नजर आएगा, इसलिए हम इस पे लॉन्गिट्यूडनली अपने ट्रांसड्यूसर को रखें।
सर सेकेंडली जब हम उसको ट्रांसड्यूसर से थोड़ा सा प्रेस करते हैं, प्रेशर देते हैं, जेंटल प्रेशर देते हैं, तो जो वो आपने बताया कि अगर वो रप्चर होगी तो उसका फ्लूइड जो है हमें साइड पे भी नज़र आएगा। अगर वो रप्चर नहीं होगी, इंटैक्ट रहेगी, तो फिर उसका फ्लूइड अगर प्रेशर भी देंगे तो नहीं नज़र आएगा आगे उसकी लिमिट से आगे।
आगे नहीं जाएगा ना, लिमिट से आगे नहीं जाएगा। लेकिन ये कि ये जो कंप्रेशन वाला टेस्ट है ना, ये हम इसके नेक को आइडेंटिफाई के लिए कर सकते हैं। जब हम प्रॉक्सिमली आके इसके नेक पे हम कंप्रेस करेंगे ना, तो फ्लूइड का जो है इनफ्लो आउटफ्लो जो है हम अप्रिशिएट कर सकते हैं इन द नेक।
सर उससे हमें ये कंफर्म होगा कि ये जो है बेकर सिस्ट ही है, फ्लूइड कलेक्शन नहीं है, और ये जो कि मतलब ये इंटैक्ट है और मतलब ये मतलब रप्चर नहीं है।
हाँ
इससे हम
बिल्कुल,
ये कंफर्म
क्योंकि
करेंगे।
हम इस मतलब सिस्ट भी हो सकता है, कोई और गैंग्लियन सिस्ट भी हो सकता है, कोई इधर एब्सिस भी हो सकता है, कोई मसल में भी कोई पैथोलॉजी हो सकती है। तो इन्हीं चीज़ों को बेकर सिस्ट से डिफरेंशिएट करने के लिए हम ये मजीद टेस्ट करेंगे। Just like this is a Piscinerinus bursa, so the location will represent us that the any bursa which is present just beneath the Piscinerinus tendon, and here in this case you can see this is graceless. Because Piscinerinus is the combination of sartorius, graceless, semitendinosus, so that is just beneath the graceless tendon. Okay. Submembranous tibial collateral ligament. So in the cases of tibial collateral ligament, you can say medial collateral ligament, there will be in some settings, there will be some bursa which will distend, that will be just beneath the medial collateral ligament and semimembranous tendon. That's why this is called semimembranous semi tibial collateral ligament bursa. But in cases of any distension, you can see over here this one. This semimembranous uh, tendon, this is medial head of gastrocnemius muscle, and this is the bursa. Okay. The prepatellar bursa is located just above the patella, and here you can see this is the patellar, and just above the patellar this is patellar, prepatellar bursal and distension. In the same way, this is patella and this is prepatellar bursa containing echogenic fluid. So care must be taken to not to miss any bursa containing echogenic fluid. So the bursa can also have this type of fluid as well. So this will be complex bursa. Yeah, or you can see this is patella and this is the prepatellar bursa containing complex fluid. Most probably that will be infectious. And here you can see superficial infrapatellar bursa. So this is infrapatellar bursa because this is just above the patellar tendon, and infrapatellar because this is below the patella. And here again you can see this is infrapatellar superficial, this is also infrapatellar superficial bursa, and while applying power Doppler and this infrapatellar superficial bursa, there is excessive amount of blood flow. It represents synovitis. Okay. Deep infrapatellar bursa. So here you can see this is infrapatellar and or this is patellar tendon, and this is a bursa just below the patellar tendon, and slightly above or caudally, capelically to this bursa there will be Hoffa's fat pad. Adventitious bursa in some cases, and some of the patient you can have adventitious bursas, and that could be either due to the repeated movement of any structure when there naturally no bursa was present, but later on due to repeated movement the need of a bursa was felt and gradually a bursa was found. In cases of some amputation of the limb, uh, there appears some adventitious bursa. Ganglion cyst. Ganglion cyst will be multiloculated cyst, and that can appear in part of the body, but especially in knee joint that will be present around the posterior and anterior cruciate ligament, and um, near to the nerves and the popliteal region. So here you can see this is ganglion cyst near the gastrocnemius tendon. This is again a ganglion cyst multiloculated containing low-level echoes in the Hoffa's uh, fat pad. Infrapatellar deep bursas, you can have peripheral nerve abnormalities. So in such cases, intraneural ganglion cyst can also be appreciated. This is in common peroneal nerve in the popliteal region. This nerve appear hypoechoic, and with meticulous evaluation, it can have a cyst with multilobulations. Muscle denervation. So here you can see if muscle is denervated. So you can, there is a comparison of two muscle. A shows increased echogenicity over here, and of the anterior compartment muscle uh, compared with the contralateral asymptomatic side B muscle. Here you can see the echogenicity is slightly lower than the denervated one. Uh, so you can easily appreciate denervated muscle with the increased echogenicity while comparing with the other side normal muscle or comparing with your own muscle. One additional application for peripheral nerve evaluation is in the settings of knee amputation. Patient who presents with symptoms of neuroma after nerve transection and neuroma as an expected finding as the narrow attempts to regenerate. Ultrasound can locate each neuroma and importantly determine which neuroma is responsible for symptoms through transducer palpation. Neuroma will appear hypoechoic in continuity with the involved peripheral nerve, and deeper neuroma may be difficult to identify in the presence of surrounding muscle atrophy, which attenuate the sound waves more as compared to normal muscle. This is amputation neuroma and vascular abnormalities. So in case of vascular abnormality, you can have pseudoaneurysm. You have already discussed in these things, and this is soft tissue hematoma and deep venous thrombosis DVT of the popliteal vein and synovial hemangioma. Sometime in the synovium there will be hemangioma that will appear the same way, highly echogenic because it is made up of small vessels, but the collective effect of these multiple interfaces will appear echogenic as compared to hypoechoic instead of hypoechoic appearance. So it was all about the knee joint pathologies, and in the next class we will discuss about the wrist joint, uh, but I think uh, we have to go through the wrist joint anatomy today to be easy
No,
for
sir.